Good afternoon, everybody, and thank you for joining the virtual brain seminar put on by Weill Cornell Medicine Brain and Spine Center and the Department of Neurological Surgery. I'm Dr. Philip Stieg. I'm the professor and chairman of the department, and I'm here to talk to you today about everything you need to know about AVMs that we can do within 20 minutes. And really, I want to focus on talking about what is probably the best treatment option for you to the extent that we can do this in a limited period of time. So there are four questions that I always think that a patient should ask. What do I have? What does it mean to have it? What can I do about it? And what are the risks associated with those options? So when one is talking about an arteriovenous malformation, you're talking about an abnormal communication between the arterial side of the brain circulation and the venous side. And the angiogram here and the cartoons here demonstrate the different kinds. This is a fistulous component where you see one or two vessels feeding into the vein and there's a dilated venous aneurysm. And these are more racemose or entangled vessels fed by small little branches off major trunks, and major trunks can branch into smaller vessels that feed this structure, which is called the nidus. And the nidus is made up of abnormal blood vessels that have all of the normal components of capillaries, but they're not in a proper alignment. In addition to that, these vessels can have more muscle than normal capillaries. The fundamental problem is that you are taking a high pressure hose, the artery, and hooking it up to a low pressure receiver, i.e. the balloon or the vein. And what happens is the vein dilates, and that is the high flow going into low resistance. There are these what are called angiomatous changes that go on. And when we look at these in children, they're not as well defined as they are in adults. Because of the high flow within the arteries, there can be aneurysms in the feeding artery. There can be aneurysms in the nidus of the AVM, and there can be dilations of the vein called venous varices, which are also aneurysmal. And the important component in terms of treatment is accurate measurement and understanding of the nidus of the arteriovenous malformation. It's also important to know that there isn't any normal brain within the nidus. The problem can be when the nidus is very closely associated with what we call eloquent parts of the brain. And by that, I mean speech cortex, visual cortex, motor cortex, and the deeper parts of the brain like the thalamus and the brainstem. So what does it mean to have it? Well, an AVM, a lot of them now are being found incidentally. And then once we know that they're there, we know that a patient that has an incidental AVM, the annual rupture rate, which is the worst thing that we worry about, is 2.2% per year. And that's not cumulative, just over every year is 2.2%. In the adult population, the most common presentation is with hemorrhage. In the pediatric population, the more common presentation is with seizures. Because the flow is stolen away from the normal brain around the arteriovenous malformation, if the AVM is close to functional eloquent cortex, we can see focal neurologic deficits. Many patients will present with headache, but as you can imagine, headache is one of the most common things patients go to see doctors for. And then if there is this steal, meaning the blood is taken away from the normal brain, there can be some cognitive and developmental disabilities in children. But the major concern we have is in the hemorrhagic presentation. With the hemorrhage presentation, there's a 10% chance of dying from the initial bleed and about a 40% chance of not making a good neurologic recovery. And by that, I mean one has a persistent neurologic deficit. So how are AVMs diagnosed? As I said, frequently patients have headaches or they have some other vague neurologic complaints. and the doctor will order a CT scan or an MRI scan. And here's what you see on an MRI scan. All these little black dots are the blood vessels within the brain. This is what's called a CT angiogram, where we inject dye into the vein, and then we do a CAT scan, and it gives us a beautiful three-dimensional picture of the AVM. This is an angiogram, where you can see dye is injected into the artery, and then we also can spin it and rotate it and get three-dimensional pictures. This is the gold standard for diagnosing AVMs. And then if there is concern that the AVM is close to eloquent cortex, we do what's called this kind of imaging called functional MRI. So we look at the AVM and what its relationship is to those important areas. What we're concerned with in this region would be that it's closely aligned with the motor cortex, meaning if it's on the left side of the body, there's the potential for motor weakness on the right-hand side of the body. In addition to the angiogram, we can also do what's called WADA testing, where a small little catheter or rubber tube is fed all the way up to the nidus, and we inject something like amytal, and we see whether the patient loses neurologic function. All of these things are being done in order to assess the size of the AVM, the location of the AVM, and the potential risk factors with treatment, such as aneurysms in the feeding arteries, aneurysms in the AVM, aneurysms in the vein, but also there can be narrowing of the venous outflow and how close it is to eloquent brain. All of those are important risk factors when we're talking with you about the intervention. So once we know that you have an AVM, we have to have a long discussion with you about what's best for you. Is it observation? Is it endovascular surgery? Is it radiosurgery? And is it microsurgery? So obviously, observation is the least invasive. Then the next least invasive is radiosurgery. Endovascular surgery is just a small little rubber tube being fed into your blood vessels. And then finally, the gold standard for cure is microsurgery, but it involves a more invasive procedure. I want to reiterate that once a patient presents with a hemorrhage, it changes the profile of recommendations, meaning that their risk profile for repeat hemorrhage goes up. The average interval when a patient presents with symptoms, and symptoms we usually think about is hemorrhage, seizures, or a focal neurologic deficit, meaning you lose some neurologic function. Any one of those three symptoms then take you into a higher category or higher risk for subsequent hemorrhage. As you can see here, rehemorrhage in the first year ranges somewhere between 6 and 15%, and the overall rehemorrhage rate is somewhere between 2 and 8%. So that is what the chances that you would take if you said, okay, I want to observe it. And it becomes our responsibility as your physician to talk about how can we lower that risk profile. And again, part of this is related to if you're 30 years old versus you're 70 years old, and whether you're 30 with a lot of other medical problems, diabetes, hypertension, high cholesterol, kidney failure, lung problems, and or you're 80 with all of those medical problems. All of those factors have to be taken into consideration when we try to put together an overall treatment plan for you. But let's start with stereotactic radiosurgery. Typically, we don't like to treat AVMs that are greater than 2.5 centimeters in size. The AVMs that are best treated by radiosurgery are AVMs that are on the surface of your brain. They have a single short feeding artery and a single short draining vein. And they have a single artery and vein. As the AVM gets more complex or bigger, the risk of obliteration goes down. If you look at all AVMs across the board, and in my personal experience, the total obliteration rate is somewhere between 70 and 80%. The obliteration is not immediate. It takes 2 to 3 years to occur. During that time, the risk for hemorrhage is equivalent. It doesn't change. It isn't reduced. And if at the end the AVM is not obliterated, we can consider doing repeat stereotactic radiosurgery, or many times we will talk about comprehensive integrated care where we use a combination of therapies to get rid of your arteriovenous malformation. Other complications related to the radiation can be something called radiation necrosis that occurs in maybe 3% of the patients. And then if the AVM is located close to eloquent brain, as the radiation has its effect on the AVM, which means that the blood vessels clot off, they form scar within them and the flow is diminished, there can be some changes around the arteriovenous malformation so that the patient has temporary symptoms, and we treat that with steroids. Embolization, as we talked about, is the next most invasive. What it involves is you would come in on the day of treatment, you are put to sleep, and a small little rubber tube is put either in your artery in your wrist or an artery down in your groin. The rubber tube is fed up to the feeding vessel of the AVM, and then glue is put into the AVM. The purpose for doing this is to reduce the blood flow to the AVM and hopefully reduce the size of the AVM. We used to combine embolization with radiosurgery to reduce the size, but most frequently what happens is you just reduce flow and the volume of the AVM is not changed, thereby it doesn't affect the total dose of radiation given over a certain area. So it's not beneficial, and there is some evidence that the glue itself may refract the radiation and diminish the efficacy of the radiation. So we're using less and less embolization with radiation, with stereotactic radiosurgery. We are still frequently using it with surgical resection. So what we will do often is staged embolizations, 1, 2, or 3 embolizations where we take away parts of the AVM, knocking off specific feeding arteries. And by doing that, we've reduced the blood flow and reduced one of the risks of treating the AVM with surgery, which is after we resect it, the normal brain around it isn't used to having normal blood flow, and there can be a bleeding risk. So by staging the embolization in conjunction with surgery, we reduce that risk of postoperative bleeding. As I said, for radiosurgery, the goal would be to try to knock out a region of the AVM, but that rarely happens. What most commonly happens is we just decrease flow within the total volume of the arteriovenous malformation. Microsurgery is the gold standard. It's what we use because it provides immediate relief of the risk for having the arteriovenous malformation. There is something called the Spetzler-Martin grading scale, where we look at the size, the location, and the venous drainage. So if the size is between 1 and 3, it gets a score between 3 and 6 and greater than 6 centimeters in size. If the venous drainage is superficial and deep, it gets a grade. And if it's located in eloquent cortex, it gets a different grade. Resection of arteriovenous malformations, in my mind, should be done at centers like ours where we have a considerable experience with managing these. This is not something that somebody should do once or twice a year. We have to have a thorough understanding of the anatomy, the neural relationships, arterial relationships, venous relationships, and its relationship to the eloquent cortex. The surgeon has to have the skill set where they understand how to treat these with microsurgical techniques. The problem with arteriovenous malformations is not only that it is a vascular lesion, but the blood vessels themselves don't behave normally. And when we use our instruments to try to cauterize the blood vessels, they don't respond like normal blood vessels do. If you go to a surgeon that talks about doing minimally invasive surgery for AVMs, I would run out of their office. This is not something where you want to be taking the AVM out from underneath bone. Unfortunately, It does require complete exposure of the arteriovenous malformation. And I would just remind you that in my lifetime, very few people have had problems because the bony window is larger. The problems are related to the primary pathology. From a surgical perspective, we always take the arterial component first and then the venous component last. And this is an example of that. You can see that this is a cartoon where we've dissected around the margins of the AVM, maintaining the venous outflow and serially taking the little arterial feeders. And we do that either with these little mini AVM clips or by cauterizing it and preserving the normal surrounding brain. When we have completely come around the arteriovenous malformation, then we take the vein and we can elevate it out. And this is just an example. It's a small AVM. That's why I'm showing it to you. You can see the AVM here. These are normal veins, and this is the arterialized draining vein. And this was located close to the speech cortex. We did a bunch of fancy functional MRI, WADA testing, and brain lab imaging. But what you can see is you cauterize with the bipolar right around the margins of the arteriovenous malformation. And then you see here, there's a little feeding artery that we'll eventually take. And we do a circumferential dissection around the AVM. And I'll just keep showing you this. It's just a slow, meticulous dissection. Blue veins like this are not a problem. It's this arterialized vein that you cannot get into, because obviously then what would happen is blood is getting into the AVM, but it can't get out. So you've got to get all of the feeding vessels first. And you can see this vessel right here is a feeding vessel that we will eventually cauterize. And I wish I could do a fast forward on, there we go. So here we've come, we're coming underneath the AVM. And as we come around the AVM, you will also notice that the draining vein, instead of being bright red, is becoming a little bit darker red. And eventually we resect the complete AVM, and now we're going to come across the vein, and at the end of it there is this. There we are. We're taking it out, and you can see where the AVM had previously bled. That is the old blood clot that we resected from the AVM. And we do an intraoperative angiogram to confirm that the AVM has been resected. And then we put everything back together the way God made it in the first place. So in summary, I want to remind everybody that there's a comprehensive way to manage arteriovenous malformations, including observation, radiosurgery, endovascular surgery, and microsurgery. And all of these are meant to be complementary. You want to make sure that you go to an institution where individuals don't have a vested interest in one particular technique. If all you have is a hammer, then everything has to be a nail. I would prefer to think that, like our institution, we're a multi-service bank, and we're here to provide you with the best intervention, best therapy that we can. This is going to be a little bit dense for many of you listening to this, but we've done a book in the past, and I know that Dr. Apuzzo is on this webinar. Dr. Apuzzo and I and Dr. Kalesi from San Diego are redoing a new edition of this, and hopefully the book will be out early next year. It will give you everything you need to know and more than what you want to know about intracranial arteriovenous malformations. So with that, I will stop talking and open the floor to any questions. Thank you very much for listening and spending time with me.
Thank you, Dr. Stieg. The first question is, what are your recommendations for a deep subfrontal AVM?
Number one, as long as the deep subfrontal AVM is not protruding into eloquent areas like the hypothalamus, or other key areas of the brain, again, I would typically recommend resection in a younger patient. It depends upon the age of the patient and the size of the AVM and the complexity. So the general of this is if you are a young patient and you have an AVM that is small, not in eloquent cortex, meaning not in motor cortex or deep parts of the brain, I personally feel that it is worthwhile to think about how to get that AVM removed. And the most straightforward way to do that is with surgery. If you're opposed to surgery and it's a small AVM, then there's a good chance that radiosurgery will work. But I will remind everybody that radiation is volume dependent. And by that, I mean that we give the same dose of radiation in stereotactic radiosurgery, whether a lesion is 1 centimeter or whether it's 3 centimeters. So obviously it's going to be more effective with the 1 centimeter lesion. When it starts getting into the 6 centimeter range, then we have to start fractionating the radiation into different regions of the AVM and hope that over time we can obliterate it, or again, with multimodality therapy, we can obliterate the lesion.
Okay, after obliteration, how is blood flow restored? Haven't you destroyed the connection?
Well, as I said early on, there is no normal brain within the arteriovenous malformation. So we're only taking the blood vessels that supply the AVM. If there are blood vessels that go by, these are called vessels en passage, we need to understand that preoperatively, and we need to avoid taking those so that there is no damage to the brain around the arteriovenous malformation. The goal is only to resect the nidus of the AVM, which I'm circling right here.
Next question is, what do you see as the future of surgery for AVMs? How is it changing?
Well, I think that in my time, there have been incredible changes. Number one, I will speak about embolization. So embolization, when I started, was using little metal coils and using horsehair. We have now progressed to having different kinds of glue. So I would anticipate that we are going to develop better agents that may be able to penetrate the arteriovenous malformation and possibly result in a complete cure. If you look up embolization, you will see in the literature a range of between 5 and 40% obliteration rate with embolization. There are some groups in France that claim 100%. I think that that's optimistic. But in any case, we're going to see better catheter technology, better ability to steer the catheter to the nidus, better glues so we can obliterate it. And then it really becomes resection of a brain tumor. You know, it's a vascular brain tumor. The microscope has gotten immeasurably better. Image guidance has gotten immeasurably better. It's still always going to be difficult to resect close to or in eloquent parts of the brain. So that will remain a surgical challenge. And in those regions, we will often defer to using stereotactic radiosurgery rather than microsurgery. We may develop other technologies. There's a thing called focused ultrasound, which we know does induce blood vessels to clot off. Once we have better models to study arteriovenous malformations, we will be looking at whether we can use focused ultrasound, which doesn't have the secondary effects of radiation, to obliterate the AVM. And then certainly there's always the hope that we will gain a better understanding of the molecular biology of arteriovenous malformations. And with that, we could induce some thrombotic or clotting mechanism within the AVM so that we could avoid surgery altogether.
Great, thank you. As we wait for more questions, do you want to go to the next screen? Your contact information is on the next 2 slides, I think.
Okay, I will do that. There we go. Questions, and then there we go.
There you go. All right. If you have any other questions, please type them in the chat box. Okay, then we are done for the day. Thank you, Dr. Stieg.
Thank you very much, and it's a pleasure to be speaking with all of you.